We will now review the 2025 Clinical Practice Guidelines for MRI Guided Radiation Therapy. Our focus is purely on the clinically actionable directives.
Here's our agenda. We'll cover the foundational requirements first, then move to specific clinical applications, and conclude with the key practice-changing directives.
First up, the guidelines scope and mandate. Let's establish the new standard of practice.
The core purpose here is to formalize MRI Guided RT. It's about transitioning this from an emerging technology into a standardized, quality-controlled clinical practice to enhance both precision and efficacy.
Okay, moving on to the non-negotiables, the team and technology prerequisites. These are the essential personnel and imaging capabilities your institution must have.
So, a fully integrated multidisciplinary team is a mandatory prerequisite. The roles you see here for the diagnostic radiologist, radiation oncologist, medical physicist, and the technologist must be explicitly defined and followed.
On the technology side, the guideline now specifies a comprehensive set of mandatory MRI sequences. This includes your standard T1 and T2 weighted imaging, FLAIR, 3D volumetrics, and crucially, the functional sequences like DWI, PWI, and DCE, along with gating. These are all required to provide sufficient anatomical and biological data for target delineation. Now for a critical point, and a frequent source of error, the distinction between simulation and diagnostic protocols for radiotherapy planning.
As this table illustrates, the protocols are fundamentally different. A diagnostic MRI is all about lesion detection. It prioritizes pathological contrast. But for an RT simulation scan, the absolute priority is high geometric fidelity and spatial accuracy. Everything, from patient position to the coils used, must be geared toward precisely replicating the treatment setup.
Let's address the central principle of target delineation, multi-sequence GTV delineation.
The guideline is unequivocal on this point. It states, and I quote, "It is mandatory to reference multi-sequence images. Reliance on a single sequence is not recommended." This means gross tumor volume delineation must be informed by a synthesis of information from multiple MRI sequences. A single sequence is no longer compliant.
And this image shows exactly why. We're looking at the partial volume effect in a brain metastasis. Notice the significant underestimation of the GTV on the thick slice images compared to the high-resolution acquisition. This averaging effect obscures tumor margins and can directly result in a geographic miss. It's a critical risk.
Okay, let's see how these principles apply in clinical practice with two site-specific examples from the guideline.
Here's an excellent example in nasopharyngeal carcinoma. The DWCC sequential identifies a subvolume within the GTV showing restricted diffusion. This is more than just anatomy. It represents a potential biological target that may harbor more aggressive or radio-resistant cells, thereby enabling advanced strategies like dose painting. And it isn't just about the target, it's also about the organs at risk. For OARs with steep dose-response curves, like the hippocampus, the guideline mandates high-resolution volumetric imaging. We're talking 1 mm isotropic voxels to ensure precise delineation and avoidance, ultimately minimizing neurocognitive toxicity. Finally, let's summarize the most critical practice-changing directives from this guideline. These are the key takeaways.
It boils down to three core mandates that require immediate integration into your clinical workflow.
Let's be explicit. Mandate 1. Establish a fully credentialed, multidisciplinary team with defined roles. Mandate 2. Differentiate your protocols. Diagnostic MRI and RT simulation MRI are distinct and must be treated as such to ensure geometric accuracy. And Mandate 3. GTV delineation must be performed using a multi-sequence MRI approach. Reliance on a single sequence is no longer compliant with the standard of care.
So this leaves us with a forward-looking question. How will this standardization of multi-sequence inputs influence the adoption of AI-driven auto-segmentation and adaptive radiotherapy? This new standard provides the necessary high-quality data foundation for these advanced technologies, creating an imperative to define their integration into future routine practice.